First, the lower lid blepharoplasty, the transconjunctival scarless approach, followed by the eyebrow region, how to tackle that.
Yeah, so I'll be covering two topics. At the outset, I would like to thank Dr. Aditi for having me in this course. It's so nice to see them growing, and today they have become one of the biggest, highest number of doing plastic surgery, not only in their places but also outside the states. Dr. Aditi practices in North India, like she had done her MD from All India Institute of Medical Science, then her senior residency in PGI Chandigarh, then a fellowship at Shankara Dev Netralaya. And it's so amazing to see the number of surgery, both aesthetic and function, that she is catering to all the people in the Northeast. And Vatsalya, the previous speaker, like she is a wonderful surgeon. And I was so happy to see that she's not only working in Rajasthan, she's going, I think she'll be very soon coming to Guwahati also, because she's going to all the states, she's being invited to all the states to perform the different plastic surgery. So what I want to say that even when we started a career, we started by attending the different conferences, and every conference you take, you learn something, and it's very essential that you really consider yourself to the student, and you have to learn it and go back and practice, because you have to learn from your own experience, learn from your own mistakes, or you see what people talk about their mistake. But it is not just saying and not doing, you have to start it, then once you start, there is no stoppage to it. So yesterday there were doctors asking me that how do we do upper lid blepharoplasty or the lower lid blepharoplasty. I'm supposed to cover only in transconjunctival, but as Dr. Shubhra is not here, so briefly I will also cover some of the aspects of the eyebrow lift. So no financial interest. So when we talk about the fat, because when we talk about blepharoplasty, it is basically we are dealing with the fat. And when we looked at the fat, the upper lid basically has got two prominent fat pads, and the lower lid has got three fat pads. And the most important structure between the three fat pads, that is the medial and the central fat pad with the inferior oblique muscle. So if you look to this animation here, the upper lid fats are much superficial. But when you look to the lower lid fat pads, it has a three-dimensional structure where the central fat pad is very superficial, the medial is deep, and the lateral is the deepest. So it falls into a three-dimensional structure. So Dr. Vatsalya has mentioned very well about the negative vector, positive vector, about the indication of the upper lid bleph and the lower lid bleph. What I want to mention that in all cases of fat prolapsing, we do not go for surgery. If you have a very small amount of medial fat pad prolapsing, you can also conceal the fat by use of different types of filler. Injection dermal filler, there is a hyaluronic acid filler, or other types of fat filler, anything you can do. But if you have something like a double convex deformity like this, and this double convex deformity is characterized by the prominence of the orbital rim, it is characterized by the lengthening of the lower lid surface area and the bowing of the orbital fat. And when you see that this orbital fat has prolapsed to such an extent, it is much anterior to the plane of the anterior lacrimal crest, and with too much of lengthening of the lid, these are the situations you have to go for the lower lid blepharoplasty. And secondly, how do you assess or how do you determine what type of blepharoplasty, whether you'll just excise the fat or you'll keep the fat and as a tissue preserving philosophy. So there's a very nice paper I'll be showing you. But what we do with the fat, we use the fat as a filler. This fat will be used as a filler, and this will be transposed into the anterior part of the maxilla down below the soak to as much as below, so that it will give a very good effacement of the lid cheek junction. Because as we age, you see there's a very prominence of the orbital rim, so it gives a double convex deformity. So you need to fill in this prominent area so that it gives a very nice effacement. So this is what we call a tissue preserving philosophy to address the undesirable progression of the aging eyelids. So this is a very nice paper. I think this is available online. You can read this paper where they have shown that in what type of surgical planning we do as per the lengthening of the lid or as per the prolapse of the orbital fat. If the lid is lengthening is very less, like in young people will find a very less amount of lid lengthening. These are the situation you can go for very customized excision of the fat, and which is a very simple surgery where you need to expose the fat. Do not pull the fat, whatever is possible, whatever comes out by itself, just excise it. But if you feel that
it is a little more, less than 19 millimeter or less than 2 centimeter. These are the situation you have to take your decision, whether you will just cut the fat excision and later do an augmentation with dermal filler or the fat filler, or whether you like to go for a fat transposition where on the table you use the patient's fat as a autologous filler. And if it is more than 19, definitely you would like to go for a use of autologous filler. So this is a nice paper, and why we have all these changes, I think Vatsala has mentioned very well, because of the soft tissue changes that we have, and these are some of the soft tissue changes, and also the bony resorption. And this she has shown very nicely what is positive and what is a negative vector. That means when we are young, so this we need a high cheekbones. They say no, high cheekbones is the beauty of every female. So when we are young, this cheek is so prominent, we have a very nice maxilla, very nice zygomatic arch. So what happens, this malar eminence is much anterior to the corneal plane. So what happens when we grow age, beside the soft tissue changes, it is a bony changes which occurs more. So what happens, this malar eminence, it goes behind the plane of the cornea. So this is what we call the negative and a positive vector. And there are multiple papers related to it. You can go through this, what is negative and the positive vector. So I am showing a small video how we do a lower lid blepharoplasty. Always for the ophthalmologist, it is not that it will be done only by the oculoplasty surgeon. It can be done by anyone, provided you know the anatomy. So it should be done by a transconjunctival approach, because if you do a transcutaneous approach, there is chance that there may be some scarring, there may be a lid retraction. So for the beginner, a transconjunctival approach is much easier. So if you just start it, then do a canthotomy cantholisis, you will get a more bigger space to work in. But if you are like, you feel that you have done a good amount, then you can go do without doing a canthotomy cantholisis. Directly expose the conjunctiva, give an incision, then you make the small incision on the orbital septum. So once you make this incision on the orbital septum, you can push the globe down and you can see the fat is prolapsing out, and it is very easy to take out the fat if you are in the correct plane. This is the inferior oblique muscle that you see here. Try to separate all the adhesion. If you don't separate the adhesion, there is chances that post-operatively there will be adhesion that might lead to diplopia. So these are the beautiful fat pads, these are pedicles that are being created, and now what you do, you need to transpose it. How do you transpose it? Because we have a very important ligament which is an osteocutaneous ligament coming from the bone to the skin, and this is known as an orbitomalar ligament which lies in the inferior orbital rim. So you have to release the ligament that you can see here, and once you release the ligament, it becomes very easy to transpose this orbital fat down above the soup as down as possible. Is it clear for you? So transconjunctival incision, expose the orbital septum, give the neck, expose the fat and fashion the fat. And better you should have a good cautery. In case you have any bleeding, just cauterize the bleeding, but do not go for excessive cautery, because chance that the pedicle flap may not survive. Okay, so this is how we transpose it. You can transpose initially when you start, you transpose with only medial transposition because you have the tear trough there medially. But as you develop more experience, you can decide whether you like to transpose the medial, lateral, central, all the 3 fat pads. So once the 3 fat pads are being transposed, you can retain this suture for approximately 10 days. And after 10 days, you can remove the suture. And then you will see that prominence of the orbital rim, which we see preoperatively as an aging change, gets much reduced. Okay, so this is at the completion of the surgery. Even if you don't give conjunctival suture, it is okay, but I usually give 1, 2 or 3 conjunctival suture for a better apposition. So these are some of the patients which we have already reported. You can see this is what we call the prominence of the inferior orbital rim. This is a lengthening of the lid, and you can see that is much less post-operatively, and this is in the side view. And this is, you can see the conversion of this negative vector into a positive vector. We want the malar eminence to be much anterior. We want the beautiful high cheekbones, and which is considered today as a sign of beauty. So this is again, I am showing a very small video just for repetition so that you remember. So what you do a transconjunctival incision, expose the 3 pedicle, and once you develop the, fashion the 3 pedicle, release the orbitomalar ligament. This is a quad blepharoplasty where we have also done the upper lid. always do the upper lid first if the patient comes to you for the lid. Because of the gravity, the blood will keep on flowing. If you do the lower lid first, it becomes difficult. So this is what, once you do the fashioning of the flap and then you transpose it and put the 3 sutures, or you can also have only a 1 flap or 2 flap as per you see how much amount of the inferior prominence of the orbital rim is being seen. So the same procedure done in the other side, and these are how the fat and also be very careful of the inferior oblique muscle, and this is the inferior oblique muscle, and then this are the transposition of the fat pen. Voice is totally gone because all these days since 12 onwards back-to-back session. So this is a post-operative. You can see this are some of the patient. So this is a very important point because there are always questions that how long this fat lasts. So this paper shows that it lasts for 6 to 8 months. But I have some of the patient falling almost for 7 to 10 years, and I could see the fat is there. It has not gone, provided the blood vessel in the pedicle is being well preserved at the time of the surgery. So these are some of the patient pre and post-operative following the surgical procedure, and these are also some young patient. It's not necessary that you have to transpose all the 3 fat pad. Even the transposition of 1 or 2 fat pad is sufficient to convert this negative vector into a positive vector. Okay, but sometimes what happens, you see patients like this. So these are the patient, you can say the whole mid-face has drooped. So this is a patient having a mid-face ptosis. So here you need to also do some amount of correction of the mid-face, like you need to do a mid-face lift, and this is the situation where you do a transcutaneous blepharoplasty. And this is a very important paper where they have shown that when you are in a supine position, the effect of gravity is not there. So what happens, the advantage is that the effect of gravity is not there, so you do not get the aging changes. So the concept is that you need to overcome the effect of gravity. So I'm showing a small video. I think Aditi, you're speaking on transcutaneous. I think I'll just skip this. So this is very important, that you just give the incision on the skin approach, and then it's same, expose the orbital septum, expose the fat. But when you do a transcutaneous approach, always excise the lateral fat pen. I like showing this patient because this is how she came to me and this is how she looks now. So these are some of the patient before and after the surgical procedures. These are also the quad blepharoplasty. So before I end, I would like to mention that all these procedures are basically done to address the undesirable aging changes, and there are different ways of managing. And also the most important thing, that patient, you have to explain them about the downtime, because many a times they'll come to you just before any celebration or marriage or some function, and they say that we want to look young. At least keep a downtime of approximately 6 weeks. Thank you very much for patient hearing.
Thank you, ma'am. I think you beautifully covered the transconjunctival approach as well as the pedicles. So that's something which I think ma'am is doing the maximum number of blepharoplasties in our country, and the pedicle approach is something, it's a delight to see it on the screen. It's even more delightful to see it in person, and ma'am does have a fellowship program as well as an observership program, so feel free to go and learn from her. Ma'am will also